Maylene or Brian, can you put up the, yeah, great. And then it looks like we have chat open. Can we close the chat except for to hosts and panelists?
Yes, it's available for only hosts and panelists.
Okay, great. So we don't have any attendees yet, so we will get started when we have the attendees joining.
Sorry to wait. Will the interpreters be assigned interpreter rights, or are you waiting to do that after?
I'm sorry, I don't think I understand the question.
Oh, as interpreters, we need to be assigned to be interpreters.
You'll be assigned as an interpreter after the third slide.
Okay,
So we're just
perfect.
going to be
Yes.
providing instructions so that it gives the opportunity for everyone to move to the channels.
Yeah,
Perfect. That's what I wasn't sure about. I really appreciate that. Thank you.
No problem.
Yeah.
Thank you.
Yeah, no problem.
Can I ask a quick question? So
Yes.
for the order of the interpreter, is there someone to name the language? So
I will do that. Yes.
Okay, perfect. Thank you.
Yeah. Yeah. Thanks for asking.
So sorry, Tori, I'm going to have to pause the slide just for a moment. I just need to access the interpreters.
Okay, great. So we have no attendees yet. We have about 60 people who have registered. And probably I will get started. I don't know, Laurie, what do you think? No later than 5:40. As soon as an attendee comes, I'll probably get started and then hopefully people will come in. Or do you want to have critical mass? I don't have a preference.
I feel like we need to respect people who get here on time. So if we start about 5:40, if we have participants, that works for me.
Okay, great. Otherwise, we may be doing a recording only, which is okay. And it'll just be a little bit of a shorter panel.
Well, assuming that if we don't get any of the registrants attending, do we just stop? I mean, are we doing?
I wouldn't. I think that we should continue on because then we'll have a recording of this, including ASL interpretation.
Okay.
Which we can still host on the website.
Okay.
And Tueri, I'm looking at, I guess Zoom has changed over the last time we've done this, but unfortunately I can't access interpretation to start, like on the third slide. It just doesn't have that option available while sharing slides. So I'm not sure if you want to just already put people in their channels already, or.
Well, if I may say something, we have, once you set us up as interpreters, for example, for Spanish, we have the option to go back to the English channel to translate for English speaking people.
All right, I'll just go ahead and start the interpretation so I can share the slides as well then.
Okay.
Thank you. Thank you, Maria.
Oh, yes. And to add to what Maria says, everyone who is English speaking would have to choose the English channel regardless so that they can hear the vice versa interpretation.
Very good. So I will be sure to say that. And if for some reason I forget, Laura, please, anybody feel free to be like, also English speaking, choose the English speaking, channel.
Yeah, they won't be able to hear us. They won't be able to hear us. That's why before the interpretation is set, please.
Yes, that's right.
Okay, so let me go ahead and set that now then, and I'll share the slides.
Great, thank you.
All right, so I'm going to choose my Spanish channel, and no one will be able to hear me unless they're on a Spanish channel or on an English channel.
I see.
I believe by default, the original audio stays on until someone clicks the mute original audio once they're in a channel. So if you're in this Spanish channel, for instance, until you click mute original audio, under your interpretation, you'll still hear the English softly in the background with the interpreter over top of it. So if someone is speaking instructions in English, they won't be completely into a vacuum if nobody's in the channel. And if you turn off interpretation completely, you're just going to get the main English channel, and that's it.
Got it. Okay. Yes.
I just joined the English channel because I could not hear you with interpretation turned off at this time.
Yeah. Exactly. So you're right about that. I actually think, Maylene, you need to unassign people and then be in the main room so we can give instructions, no?
Okay, we could do that.
That's what we
believe
usually
I
do
started-
in the Board of Supervisors public session meetings,
Okay.
is we give instructions with interpretation turned off, but the interpreters can be assigned then.
Yep.
And then
Let's
there's
do
a
that.
point in time where we cut over and assign all the interpreters to their channels.
All right.
Yeah, let's do that. And then I'm noting that Stephanie doesn't have access to the Q&A.
The Q&A should be at the bottom of her screen.
Yeah, she said she has access to chat only, but
Hmm.
When I go into the Q&A, it says that only panelists and host have access.
Oh, well, I mean, there's no questions yet.
there's no
so-
questions.
So
So
that's
you
why
have
there's
access.
nothing there. But you have
Yeah.
access, yeah.
Okay, thank you.
Okay. So what I would request is that, with the exception of our ASL interpreters, that unless you are speaking, please turn your camera off so it's not distracting. And then I will, we'll go from there. So I think that we should just go ahead and get started. It is 5:40. And Maylene, if you can put up the opening slide, we will start.
This is the Tiffany's Vietnamese interpreter. I did not get assigned for my language.
Yes, we're going to do that after slide 2, Tiffany.
Okay,
Because
yeah.
it was
So if
creating
you do
some
that,
problems.
Please do the INT Vietnamese Tiffany because I have a 2 device logged in. So you
Okay.
click on INT Vietnamese Tiffany. That's one you need to assign me. Thank you.
Okay, very good. Maylene, did you get that?
Got it.
Okay,
Thank you.
great. Okay. All right, well, let's go ahead and get started. Hopefully people will join.
Vamos a comenzar. Primeramente, se reúnan.
Okay, good evening and welcome everybody to the Alameda County Emergency Medical Services
Muy bien,
System
bienvenidos a todos
Redesign.
por el sistema el rediseño del condado de Alameda, su sistema de servicios de emergencia.
Thank you so much.
Laura, te están... Okay.
Oh,
This is our Community Education Engagement and Input Community Forum. We welcome you all to be here this evening. Next slide, Maylene. We do have interpretation in Spanish, Vietnamese, and Cantonese. I would like to invite one of our Spanish language interpreters to translate, to interpret the slide here in Spanish so that people can access the language.
Para la siguiente presentación tendremos interpretación en español, vietnamés y cantonés. Para comenzar esta función, por favor, pulse el icono de interpretación, que es el globo terráqueo, al fondo de su pantalla, y seleccione qué idioma desea escuchar la interpretación.
Thank you. I would like to invite one of our Vietnamese interpreters.
Kính thưa quý vị, những quý vị nào muốn tiếp cận biểu thông dịch của tiếng Tây Ban Nha, tiếng Việt và tiếng Cantonese, xin quý vị bấm vào cái icon chữ Interpretation và cái quả địa cầu, tức là cái hình quả địa cầu. Sau đó quý vị sẽ chọn cái ngôn ngữ của mình, tiếng Tây Ban Nha, tiếng Việt hay là tiếng Quảng Đông là cái ngôn ngữ mình chọn. Nếu mà quý vị có muốn nghe vào những tiếng này, những ngôn ngữ này thì xin bấm vào cái chữ mute để tắt âm thanh gốc. Xin cảm ơn.
Thank you. And I would like to invite one of our Cantonese interpreters to share the instructions.
如欲獲得廣東話、越南話同埋西班牙語即時口語服務嘅參加者，可以喺熒幕嘅下方單擊個地球儀一下，進入去選擇語言。如果你想淨係聽到我哋廣東話嘅口語服務，請你喺嗰度選擇靜音原有嘅音效。如果你用流動裝置進入呢次會議，請你喺角落頭嘅3點裏邊單擊，亦都可以選擇到需要嘅口語服務。多謝。
Thank you. Maylene, if you could please open our language channels. And while Maylene is opening those channels, I would like to introduce myself. My name is Tueri Anderson, and I serve as the Director of Systems Integration for the Alameda County Healthcare Services Agency. I will be the moderator for tonight's community forum, and I am very happy to be with you here tonight for this important community meeting. So on the agenda, just a few housekeeping pieces, which we've already taken care of, although I will say, please mute your microphone when you're not speaking, and panelists, please stay off camera until you are speaking. And then for all of our attendees, please ask your questions in the Q&A function here. This evening, we will have a small panel presentation followed by a question and answer session where the audience here, we are encouraging you to be in dialogue with us around the emergency medical services or EMS system redesign. Next slide, Maylene. Okay, so with that, I would like to turn this over to Laurie Mcfadden, our EMS director. Welcome, Laurie.
Thank you so much, Tueri. It is a pleasure to be here. I am happy to be presenting an overview of our system redesign as we are looking at a couple of year time frame where we need to start connecting with a RFP for our ambulance system provider. So the reason we're here asking input from you is we are interested in people having equitable access to all services, fiscal responsibility, as we all know, if we are not responsible fiscally, we can't sustain our organizations and our services. And we want to have appropriate destination for all patients. And so you'll see a very different design as we move through this presentation. And sustainability, we want to be sure to take care of our healthcare providers and take care of our communities and our patients, do prevention, all of that. So next slide, please.
Laurie, I'm going to ask the ASL interpreters to switch.
So now is our chance to make our EMS system better, and we need community feedback to accomplish that. We've already begun with meeting different populations in our county, and we have more planned. So this is part of our desire to get the right system for everybody. And user experience, system partner feedback, and technical regulatory requirements inform the system redesign. So there are many pieces that go into an emergency medical system. So some of that is not our choice, but much of it is. So we're excited to present that to you. Next slide, please.
Laurie, I'm going to ask you to hold for just a moment, please. It seems that we're having some challenges with our attendees getting access. Can I ask my colleagues in ITD to support by resending out the Zoom link to all of the attendees? And so we will hold for a few minutes here.
Oh, Twary, so IT did not send the link to the attendees. They were provided though to HICSA to send out using the registration that they opted to use for this event.
Okay, I will take this offline with Jerry. Thank you. Why don't we pause here for just a moment so I can troubleshoot this with our HCSA colleagues. One moment, please. Okay, greetings, everybody. Sorry for the tech snafu. Eunice, in response to your question, you do not need to leave. We are working to make sure all of our attendees can join. It will be a few minutes. We will start over, actually, is what we're going to need to do. So Maylene, if you could go to the very first slide, that would be great. And then we will start over. Thank you. And if
Does that
anybody's
mean,
watching, yes?
does that mean that recording everything can start over so we can post it fresh?
That's a great question, Maylene. Is that the case? We can do some post-production editing, Laurie.
Okay, that'd be great.
And I appreciate the patience of all of our interpreters as we make this go. Flexibility is key these days, that's for sure. I bet we've all had very busy days, so we can just take this as a moment to take a breath. Okay, good evening, everybody. I see that your folks are starting to come in. We are so sorry for the technical difficulty. I was surprised that folks weren't here. So we're going to give it a few more minutes to have more folks join, and we're going to start over and hopefully just move forward. Appreciate your patience. Sorry for the delay. And this is being recorded, so we will be sure to keep it going. So stand by and we'll get started shortly. ASL interpreters, please switch. Good evening, everybody. I'm going to give it another 2 minutes since we did have some difficulties in getting people the link. We apologize for that. Thank you for joining, for your patience. We're going to wait for a few more folks to join, and then we will get started. Thank you. Maylene, we're going to have to restart the interpretation so that folks can hear the instructions in language again. So if you could please turn off the interpretation channels. Thank you. Thank you so much. Okay, appreciate everybody who's been able to join. I'm sure we will get more folks coming on. Maylene, if you could start the slide deck, please. And language interpreters, this first slide I will talk through. You don't need to interpret, but then I will call you in for the second slide. Please stay on the first slide, Maylene. So welcome everybody. Late, better late than never, as they say, to the Alameda County Emergency Medical Services System Redesign, the Community Education, Engagement, and Input Community Forum. I will be your moderator for today. My name is Tuweri Anderson, and I serve as the Director of Systems Integration for the Alameda County Healthcare Services Agency. Next slide, Maylene. We do have interpretation today. American Sign Language will be pinned throughout the entirety of this presentation. And we also have Spanish, Vietnamese, and Cantonese. I will invite one of our Spanish interpreters to read these instructions, please.
La siguiente presentación tiene interpretación en español, vietnamita y cantonés. Para empezar esta función, aprieten por favor el icono de interpretación, que es un mundito. También seleccionen español, vietnamita o cantonés, como sea su preferencia. Opción es para oír solo español, vietnamita o cantonés. Entonces denle clic en Mute Original Audio o poner en silencio el audio original.
Thank you very much. And now I invite one of our Vietnamese interpreters to share the instructions.
Yes. Kính thưa quý vị, cuộc trình bày của chúng tôi ngày hôm nay sẽ có 3 ngôn ngữ, tiếng Tây Ban Nha, tiếng Việt và tiếng Quảng Đông. Để bắt đầu chức năng này cho những quý vị sử dụng PC, Android, iPhone hay là Mac, xin quý vị bấm vào chức năng quả địa cầu. Sau đó chọn ngôn ngữ của mình, tiếng Tây Ban Nha, tiếng Việt hoặc là tiếng Quảng Đông. Nếu mà quý vị chỉ muốn nghe tiếng Tây Ban Nha, tiếng Việt và tiếng Quảng Đông mà thôi thì xin quý vị tắt âm thanh gốc. Xin cảm ơn.
Thank you. And now I invite one of our Cantonese interpreters to share the instructions.
歡迎各位今日出席呢個座談會。 呢個座談會將會提供美式手語、西班牙語、越南語同埋廣東話嘅即時口譯服務。如欲獲得即時口譯服務，請你喺個熒幕嘅下方單擊地球嘅圖示進入去選擇語言。喺你如果只係想聽到你所聽嘅語言嘅話，唔想聽後邊嘅英文翻譯嘅話咧，英文原音嘅話，請你單擊靜音原有音效。如果你係用流動裝置上網嘅，請你單擊角落頭嘅3點，同時都可以選擇到我哋嘅即時口語服務嘅。多謝 ，thank you。
Thank you. And now, Maylene, if you could please open up our language channels. Wonderful, thank you. Next slide, please. So welcome everybody once again. We appreciate your patience in joining us this evening. You know, the best laid plans sometimes don't plan out. So here we are, human as always, just glad that you could be here and join us this evening. So I welcome everybody to the Alameda County EMS System Redesign Community Forum. Please, panelists, mute your microphone and turn off your camera if you are not speaking. And then for our attendees, please ask your questions in the Q&A function. You can ask your questions anytime throughout this presentation. We will be joined this evening by our EMS Director, Laurie Mcfadden, and the EMS Deputy Medical Director, Dr. Jocelyn Freeman. So we're excited to hear from both of them about the EMS system and redesign. And then we want this to be an interactive engagement with you all. So please do ask your questions and our panelists will be on deck to answer them. With that, I turn it over to Laurie Mcfadden. Next slide.
Thank you so much, Tueri. I'm so happy to be here and I'm happy to have you all here. And why did we ask you here? We asked you here because we want to talk to you about the emergency medical services system redesign. And basically, most people know that as the 911 ambulance system. There is more to it than that, but that's basically what people think of when we're talking about this. So we wanted to bring you here to listen to what you have to say. And in our hearts and our goals, we want equitable access, fiscal responsibility, appropriate destination for all patients, and sustainability. Next slide, please. So now's our chance to make our EMS system better, and we need your feedback to be able to accomplish that. And there are several things that go into a system redesign, and we want user experience, our system partner feedback, and technical regulatory requirements inform the system redesign. So we need to consider all of these pieces in order to follow the laws that dictate various things in an EMS system. But also we want to make sure that our community's needs are met as best as possible under the auspices of the emergency medical system regulations. Next slide, please. So right now, this is our EMS system by the numbers. We have 5 transporting ambulance services in our area. The fire departments for Albany, Berkeley, Piedmont, and Alameda do their own ambulance transport. And for the rest of the county, there is a private provider named Falc, like Falcon that you see on the side of their ambulances. They do the rest of the county ambulance services. And we have 6 fire and emergency medical services dispatch centers. We have 10 fire departments, and those fire departments who are not transport, they are actually first responder advanced life support engines. And that means that they have a paramedic on the engine so that they can render aid quickly when the fire engine arrives. Because sometimes, the ambulance is a little bit farther out. So the citizen can get care immediately. So that's been in place for many, many years. We have 14 interfacility ambulance providers, and these typically perform the non-emergency kinds of transports, say a discharge from a hospital to a skilled nursing facility, or different movements in between hospitals, maybe for specialty care. And so we have 14 of those ambulance providers, 15 911 receiving facilities. 3 of them are trauma centers. So those for things like major accidents, just terrible injuries. They go to trauma centers. We have 7 what we call STEMI centers, and basically that's for cardiac care. And then we have 8 stroke centers and 2 behavioral health facilities, one that deals with adults and one that deals with adolescents and young. And then Children's Hospital deals with the younger children. And then our calls per year, ambulance calls, it's approximately 160,000 calls per year, and 50% of those calls are in the city of Oakland. Next slide, please. So we're at a crossroads. COVID has shown us strength and weaknesses. And some of the biggest challenges facing EMS systems right now are addressing community needs. We all know that there are gaps in our service, and some of those are mental health. That's probably highest on our list, and just making sure people get the right destination at the right time so that their needs can be addressed by the appropriate specialty care. Then there's a system structure. I told you about the regulations in EMS services, and some of the reimbursement avenues are not good, and we'll talk about that in financial stability. So the system needs to be shaken up a little bit as well. And then with the way our hospitals are right now, as we've seen with COVID, there's always an issue of hospital saturation. Just without a pandemic, there are days when hospitals are very, very busy. And for any of you who have ever visited an emergency room, you probably have seen that and have had to wait. I remember when I broke my collarbone, I waited for hours in the waiting room. So it's a real thing, and it's something that we're dealing with on a system-wide solution. But if we take people to the right destination, a lot of times that isn't an emergency room. So that would help with the hospital saturation issue. Staffing is always something that we deal with in emergency medical services, because there are so many opportunities for an EMT or paramedic to use this career as a launching board for something else. Firefighter, physician assistant, nurse, doctor, there are lots. So we have staffing issues. Financial stability. One thing that we found is the cost of rendering service has not been mirrored by the reimbursement. I'm sure that surprises you. And so we're trying to figure out ways where we can work around the fee-for-service models and try some different things. And we'll be talking about those a little bit later. And that segues perfectly into the one pathway model. We'll be talking about right now for reimbursement, an ambulance company has one way to get reimbursed, and we really need to change that. Next slide, please.
Thank you, Laurie. I'm going to ask that the ASL interpreters switch, please. And Laurie, I will ask for you to put on your video so everybody can see you.
Oh, I thought it is on. It's been on this whole time, I thought.
No, we see you now.
Okay.
Okay. I didn't change anything, so.
Okay.
Oh, I love technical issues.
Yeah, 'tis the season. And then I will ask Maylene to make sure to pin and spotlight our ASL interpreter, Destiny, please. Thank you. Okay, carry on. Thank you, Laurie.
All right, thank you. So as I was talking about the one pathway model, right now our current 911 ambulance response is 911 is called by a citizen. The call is answered and triaged by a dispatch center. Remember I said there are multiple. The available ambulance is sent to a call, And then they are transported to a hospital. If they need care, they are transported to a hospital. And then the ambulance provider drops off the patient and transfers patient care at the hospital. And then you can see if that's an active link in our to our EMS website, and it gives you all of the system statistics about, our different metrics that we measure. So it's something that you can look at a different time. Next slide, please. So now this is a very busy slide, so stick with me because this is the exciting piece for me. So what has happened is we want to put some things at the beginning so that people don't even have to call 911. So one of the things that we're thinking about is called prevention. And we're doing that through community education. This is the beginning of it. And community paramedicine. And I'll talk about that a little bit later in more detail. So then if we can get the community education and community paramedicine effective enough, they will divert people from the EMS system. But there's always going to be issues when 911 needs to be called. So in the new system, say someone picks up the phone and calls 911, and the call is still answered and triaged by dispatch. But what we see here is there are 3 different routes that people can take. So in one case, if they do need a resource, an actual transport resource, we will go ahead and send them as we do now. But what's different is that we may take them to someplace else, or we may actually refer them. So what that means is if they really need medical care and they need to go to an emergency room, then they will absolutely be taken to the emergency room, and the wonderful folks there will take care of them. But we also may be taking them to a crisis stabilization unit or something along those lines so that they can get mental health care, they can get appropriate care, maybe a sobering center, something else rather than just a hospital emergency room where a lot of people's needs are not going to be met, no matter how hard those hardworking folks try. And in other cases, we may not transport them to a facility. We may actually say, looking at their community health record, oh, I see that you see Dr. Freeman. So we're going to make an appointment for you and send them to the doctor the next day if their needs are not emergent. And so then what can happen is after they're discharged from the hospital, a community paramedic can follow up, and I will go a little bit more on that in a minute. So let me finish the 3 different routes, and then we'll talk about then what the follow-up care is. So if they decide that by listening to the call that a transport resource doesn't need to be sent, a dispatch center clinician will actually talk to the person and give them guidance. For those of you that have Kaiser, it's something like the Kaiser advice line. And so they would give them guidance or a referral, just like we talked about earlier, or give them connections to resources so that they don't have to endure an ambulance transport or the bills that happen in the emergency room and things like that, so that we can keep them out of the EMS system when it's not appropriate. And the other piece that we can do is telemedicine. And there have been some great pilots with telemedicine, and through the pandemic, as you know, the telemedicine has been used to the nth degree, and it has been very successful in certain circumstances. We're not going to use this as any kind of replacement for face-to-face care, but there are certain areas where telemedicine would be very effective in keeping people out of emergency rooms and getting them care more appropriately and more quickly. And so we can get them wraparound services and lots of different things to help with some of the social determinants of health. So we're very excited about that. So those are the 3 different routes a person could be sent down as they are triaged by dispatch. But then there would be follow-up care. What we envision is, say Mrs. Smith went into the hospital and she had some issues with her congestive heart failure, and she needs help staying on track with her medication. That's where a community paramedic would fit in, because then they could visit Mrs. Smith at home and make sure that she takes her medicine and that she has her timer set and things like that, so that they can be sure to keep people out of the emergency room. And so obviously it would reduce readmission to hospitals, save lots of cost for the people who are going to the hospital. And also it makes it easier for the hospital planning and throughput if there are obviously less readmissions, and it would reduce repeated 911 activations. We have different people who use 911 for their primary care because they don't have any other options. So we want to be sure that these people are handled personally and carefully through one of these different routes, and so that we can connect them to a medical home. So there's lots of plans for wraparound service and follow-up care. So this is a lot of talking about our Envision system. So I hope that was clear to you. And then we'll give you some examples, and I'm going to ask Dr. Freeman to go through some examples to help solidify this in your brain a little bit.
Thank you, Director McFadden. And we have two scenarios that follow on the next slide. The first scenario, for example, involves someone calling 911 due to ear pain. And it feels like a previous infection they had, but they cannot get to a primary care provider. They may not have a primary care provider. They don't have a car. It's 8 o'clock at night. They don't feel comfortable going by Uber with COVID or catching public transportation. So they think their only option is 911. Continuing on with the scenario with our current scenario, if you advance the slide, they call 911, dispatch deploys them to a medical provider, which will be an ambulance or a fire transport provider who assesses them, and they take them to one of those 15 receiving facilities that Director McFadden mentioned. They wait in the emergency department, they get registered, they eventually, hopefully, get to a room. I just left a shift at our county hospital in the ER, and we had no beds because of COVID and people waiting. And you might get seen in fast track after a couple of hours, and you get a bill for being seen in the emergency department and for the transportation to the ER for ear pain. Ideally, this envisioned experience that Laurie Mcfadden outlines is a dream for me as a citizen of Alameda County, as an emergency physician who sees the impact of the system, and that there's a better way to deliver care that they're trying to do. So as the slide advances, it would be fantastic if there was a clinician available, whether that's a nurse practitioner, the advice nurse like Director McFadden mentioned, who could be on the call. So when dispatch gets the call, they can transfer to a clinician who can say, you have ear pain, you've had this before, you got treated with antibiotics and pain meds. We can call you in a prescription and ensure you can see a pediatrician if you're underage, or a family physician the next day or in the next 2 days. Because this is urgent. The urgency is the pain in this scenario, but the patient doesn't know that. They don't know that they don't necessarily need to see a doctor, but we want them to be pain-free, so we can give them some pain medicine and then have them see the appropriate physician or physician assistant the next day. That prevents them from having to leave their home, go to transportation, get a bill for being seen in the emergency department, which is much higher than what could be billed just to speak to a clinician. Telemedicine is great. We're having this meeting right now through this virtual option, and this is popping up everywhere in the medical field. Maybe they can just have a virtual visit with an emergency physician who's on call just for some of these issues, and they can talk to the patient, give them some reassurance, and help them get a prescription for pain medication if that is reasonable, and that person will be able to get to the pharmacy to get those meds. We have another scenario as another example, and commonly what I saw just on my last shift, and we see a lot more now. Someone can just be having a mental health issue that is urgent. Right now, if 911 is called, even if the person isn't exhibiting violent behavior, but if they're responding to internal stimuli because they're hearing voices, they're not suicidal, but they seem like they may not be able to fully care for themselves, then as the scenario unfolds, right now, 911 would be called maybe by the patient themselves or a concerned citizen. A fire or an ambulance would be dispatched, and then the patient would either go directly to John George, but right now, because everyone, about 2 weeks ago, 40% of our at-risk areas were COVID positive. Now it's 20 to 25% of our population in Alameda County has COVID. Everyone has to get a COVID screen, so they have to go to the emergency department, and then they get billed for transferred first to the hospital, then to John George once they get medically cleared. However, if they don't necessarily require a 5150, meaning they're a danger to themselves, they're a danger to others, or they're unable to care for themselves, maybe they need some de-escalation, maybe they need some behavioral intervention, and you can see that something triggered them to be in this state where they seem unable to make rational decisions or care for themselves. And you could address that. Maybe they just lost their job and that triggered their borderline issues. Maybe they're having housing issues. If you had someone who specialized in behavioral health, who was on a street team, who could reach that patient directly and meet them where they are, that would be phenomenal. And we have a CAT team now that can do that, community outreach, to address these behavioral health issues, or the paramedicine program that Director McFadden was mentioning. That would be ideal. Versus in some of these cases, you get on a 5150, that could be traumatizing to the patient. You transport them in the back of an ambulance, which could be claustrophobic inducing for some people. You get them to the ER where there are a lot of sick people, and they wait to get a medical clearance when their initial issue was really behavioral health. But in the ER, we're addressing medical clearance to eventually get you to behavioral health. So it's a delay, ultimately, in addressing the root cause of this patient's issue. Next slide, and I'll turn it back over to Director McFadden.
Actually, Dr. Freeman, if you wanted to speak to your experience as an ER doctor and really kind of talk about, if you wouldn't mind for a moment, you have a very unique and important role here in our county, both being a practicing physician in the emergency room, as well as your role as a deputy medical director for EMS. So if you could speak a little bit beyond what you have just done to your experience being an ER doc and the work that you're doing here in Alameda County as the EMS deputy medical director.
Thank you, Tuweri, for reminding me. That was a very nice way, facilitation, that I have another slide.
And actually, I'm going to take a pause to have our ASL interpreter switch as well. Thank you, Destiny. Welcome back, Naomi.
I'm happy to elaborate, and because I have had a foot in each side, and it's helped me to have a better picture of all of the opportunities in our system, how great our system currently is, but how we can make it even better to equitably address some of the issues. I think the biggest one was that scenario 2, which I appreciated them putting in behavioral health. You know, it's really frustrating as an emergency physician when some people come in and they wait for an hour or two because they just need follow-up, and they just got released from Santa Rita jail, or they just got out, you know, of a skilled nursing facility for rehab, and they need follow-up to get a medication refill. And they sometimes take an ambulance, or they just come to the ER, and they don't have to do that, but they don't know. so that the beginning part of what Director McFadden was talking about, the education, we have a huge opportunity to educate all of our stakeholders, all the community-based organizations, the system, the receiving hospitals, and our public. My dream really is that just like people know now, if you're having difficulty with speech and you're having difficulty moving your arm, you could be having a stroke. 40 years ago, the general community didn't know that. They didn't know if you were having chest pain that radiated to your neck. And if you felt like you were breaking out into sweat, you could be having a heart attack. There was a public health campaign to educate our citizens about that. And we have the same opportunity now. What is the best use of the emergency department? What resources are available to you? This is who you call if you're having a mental health emergency, and this is who can help you. 211 can help you with transportation if that's really what you need. But how many of our citizens really know about the bifurcated response that could be available to them. In the emergency department, that's largely what I see is people come because they think that's their only option, and they think they should call 911 to get there. So if we can educate them about the process and set appropriate expectations, I think it'll help people feel more respected in the process because they understand the process.
Thank you, Dr. Freeman. It's really important to have that perspective from the field. And like I said, you're in a very unique position. So there may be more questions or opportunities for you to share your experience. And for now, we'll turn it back over to Director McFadden.
Thanks so much, Dr. Freeman. That was wonderful. Next slide, please. I'm not going to go through this whole slide, don't worry. I just wanted to let you know that we have been meeting about this since 2019. We've been working on this system redesign, and this is what our system partner work group, they recommended, and this is actually up on our EMS website, as will this recording be and the slide presentation. But we did talk about financial stability, taking care of our workforce, making sure we take care of the patient, just, you know, really digging in and talking about what the community needs are and taking care of our patients in the best way possible, and tracking our performance. That's important as well. And keeping up to date with technology. That's something that we've lagged behind. So we're really interested in making sure we keep up with technology. Next slide, please. So our redesign timeline is fluid. So you'll see a lot of asterisks, and that's because there are just a lot of moving pieces. We're continuing our community engagement and education, actually probably through mid-February. And see that one hasn't been updated. And additional input will be accepted through mid-February at this email address, and that's ems.redesign@acgov.org. So that's through mid-February. And we will be hiring a consultant to help us with the actual procurement process and the design, as well as working through the contractual agreements and things like that. And then we will be doing the actual RFP development sometime, probably summer to fall. Then we'll release the RFP in the fall and get ready to complete the process and get a contract, as well as be ready for the next provider to be able to put their systems in place before July of 2024. That is when our current contract without extension with Falck ends, is July 2024. So that's what we're aiming for, is to be able to, whoever bids successfully, have a year to stand up their operations to be ready to go in July of 2024. Next slide, please. All right.
Okay.
It's all yours.
Thanks. It's about to be all yours, actually. So there have been a few questions that have been coming through here in the Q&A that are being answered offline. I actually think I'm going to read the questions and then read the responses so that folks can hear them, that we're preserving them for the recording. So why don't I go ahead and get started? And please, I'm inviting everybody who is joining here to add questions to the Q&A, and we have some time to continue to answer those questions. Okay, this first question is, it's really important and gives a lot of context. So the question is, I want to ask about people who are drunk, homeless, on drugs, mentally ill, people with disabilities, elderly, etc., and how some folks fall through the cracks on the street or get ejected from the hospital due to bad behavior. I'd like to understand where these folks and how these folks are supposed to get help if they're under the influence or cannot normally ask for care, or if at a facility are acting inappropriately, etc. How do we get these people help so they get the care they need and don't die on the street due to the weather, for example, at 5 a.m. in the morning, or exiting a sobering cell, for example, at jail, or in a hospital, or a hospital ejects people on the street? What can be done for these folks? People end up dying. That is not a goal. What is another place that they can go if they can't go to where they need to go? Is a 5150 required for a crisis center? So there's a lot of different things in that scenario. I am going to read first the answer from Stephanie Lewis, who is our Director of Crisis Services in Alameda County Behavioral Health. I will read her answer, and then I will invite you, Dr. Freeman and Director McFadden, to answer as well. Stephanie's response is, Alameda County Behavioral Health has many outreach teams for individuals in need of care. We have mobile crisis teams for urgent response and other teams for response to individuals with more chronic issues. Our teams can transport to a sobering detox center or crisis stabilization centers, for example. For more information or to refer individuals, anyone can call Alameda County Behavioral Health Crisis Services at 510-891-5600 and speak with an on-duty clinician Monday through Friday, 8 a.m. to 6 p.m. A voicemail can be left at any time. There is a follow-up question to this, but I will turn it over to you, Dr. Freeman, and Laurie, to weigh in on this particular question.
Thank you, Tuweri. What I recall, there were about 4 or 5 important points and sub questions was, and I'm speaking now as an emergency physician, by law, you cannot release someone who is under the influence of drugs back into the street. You have to have them sober up and be competent, or you are liable while they're under the influence and their judgment is clouded. But if they have underlying mental health issues, DSM-4 diagnoses like schizophrenia, schizoaffective disorder, bipolar, etc. Sometimes, to your point, you said, is there something else besides a 5150? Sometimes a 5150 is the easier option. It's harder for me personally when I have someone who I can't place on a 5150, but I know they have mental health issues, because when I offer them housing, when I offer them the ability to talk to a case manager or a case worker to help them with their homelessness or their issue because I think they're making poor decisions, I can't. and you know that they're mentally unwell, so they're not being completely rational, but they're not homicidal, suicidal, or a danger to themselves, you're stuck. So in the medical field, you feel like you're just waiting for a time bomb to explode because your hands are tied by what you're able to do. If we had other resources like we're describing in this system that we can refer people to, and everyone's informed of those other resources, like our behavioral health crisis leader, Stephanie, mentioned, that would be better. But usually the client or the patient, for me, is refusing the services because they're most comfortable to go back to that corner that they are comfortable with. I'll stop there.
Great. Thank you so much, Dr. Freeman. Laurie, do you want to add anything to this response?
I sure would. So some of the issues that were raised with homelessness and some of the mental health issues, obviously our crisis teams would respond to that, but also our community paramedics can work with that as well. Some of my colleagues throughout the state have done pilot programs with what they call familiar faces, people who have chronic homelessness and other medical or mental health issues. And so they would meet with them on a regular basis to make sure that they're getting their food and they're getting to a shelter if need be, and some other options. So that's actually been leveraged successfully in other communities across California. So I think we could also bring the community paramedic into the solution as well.
Great, thank you so much. Like I said, there's a follow-up to this question. So I will read the follow-up question from our attendee. She says, thank you, Stephanie. I hear that they're saying that there's someone on call. However, the ACBH, Alameda County Behavioral Health Crisis Services, they're only available from the times listed and does not cover 24 hours. And because of COVID, there are less beds available. We need 24-hour care. Yes, there are as well temporary necessary services. Will we get something like CAT, Community Assessment and Treatment, in Berkeley? And Stephanie's response is, Berkeley has a mobile crisis team. It is not clear if Berkeley will receive a CAT program. And just so folks are aware that the city of Berkeley has their own local health jurisdiction. So they set their own policies and procedures in conjunction and in partnership with us here in Alameda County, but they are a separate health jurisdiction. There aren't any mobile teams in Alameda County that are 24 hours currently. CAT is providing care 7 days a week. There is a 24/7 crisis line, which is 1-800-309-2131 that individuals can call for support. Additionally, our crisis stabilization unit accepts clients 24/7. So that is the follow-up to that. There are additional questions. Before I move on, I will ask our ASL interpreters to switch.
While they're switching, thank you, Tueri. I just want to comment to whoever submitted that thank you for raising it, because it's a challenge every single day for the system. And I know it wasn't exactly, the EMS system, but it's something Director McFadden and Assistant Director McClurg are really working on. And I think it's going to be helpful for them to look at those alternate resources in off hours or the overnight shift to be available. So thank you for lifting that up.
Yeah, that's great. And just to piggyback on that, one of the reasons I am reading out the chat and the questions that have been answered is so that we can have this record to help inform the system redesign. So all the questions are really important and thought-provoking as we think about the redesign. Next question, regarding telemedicine language accessibility, are these services available for non-English speakers. And our Deputy EMS Director, Will McClurg, answered the question saying, most places that have telemedicine in place have options for multiple languages. As we evaluate the use of telemedicine in the 911 system, support in multiple languages will definitely be addressed. Laurie or Dr. Freeman, is there anything you would like to add? Okay, great. All right, next question. This is a great, thank you. This is a great presentation. However, I was unable to see any presence of community-based services in this workflow, especially on the social determinants of health side. How do you envision the role of community-based organizations in this new system? How can we partner with EMS to better serve our mutual patients' clients? And Deputy Director McClurg answered, community-based organizations will play a significant role in the system we are envisioning and attempting to build. Having a robust group of organizations to provide wraparound services and to provide referrals will help provide more definitive care for our community members. So Director McFadden, I'm going to pass this over to you if you wanted to add to that.
Yes, so community-based organizations are very important to us. In fact, we are meeting with several of them, the providers in different spaces like older adults and youth and access and functional needs folks, because we do need to hear about this. And we are working with CBOs through crisis stabilization units for the CAT team and things like that. So this is not something that will be dismissed at all. In fact, through COVID, it has become perfectly clear that our trusted messengers and the people who get the work done are on the streets, and there are partners in the CBOs. So there will be a lot of interaction with our partners. We can't do it without them. So, you know, when we talk about the wraparound services and referring to clinics and different areas, those are all of our partners in CBO space as well as you know, medical care space. So that is something that is clear to us that we need to engage, especially for the social determinants of health. And you know, based on the we're hoping to get access for our paramedics and EMTs into the community health record, and that will also help educate them what the patient's needs are and how they've been how they've gone through the system. So it's very important. That's an excellent question. Thank you for that.
Great. Thank you so much. We have one more question that had been answered in the chat. I will ask our attendees, if you have any further questions, please go ahead and put them in the Q&A. Otherwise, we will close with this particular question. Is there a specific plan to address the unique needs of older adults, especially people with memory impairments who are challenged in navigating their care? Deputy Director McClurg answered, we recognize that older adults, especially those with memory impairment, create unique challenges. This is another example where community-based organizations can be a key resource, as well as being able to link in social services and behavioral health resources from the county. This will definitely be something that is factored in as we build the infrastructure of a new system. Director McFadden, is there anything that you would like to add?
Certainly. This is another area, sorry, I've been thinking about this a lot. The community paramedicine is part of the solution as well. Because if we can help those people who have memory issues, technology issues, just for different reasons, a community paramedic can move within the community and help these people so that they don't need to engage in some of the more problematic venues. So that's what we really see between the CBOs and the community paramedic, that we can get a lot of leverage just keeping people where they live, you know, whether it be at home or in a skilled nursing facility, assisted living. We just want to keep them comfortable And we know that for the older adult population, that every time they get transported, they are at risk for not good outcomes. So we really want to stop transporting them if we don't have to. So our CBOs and our community paramedic process, I think, will really help with this.
Great, thank you, Director McFadden. And Dr. Freeman, I don't know if there's anything else that you would like to add?
No, nothing to add there.
Okay, wonderful. So unless there's any further questions from our attendees, oh, it looks like something came through. Oh, here's an interesting question. Sorry, it took me a little bit to figure out what I was asking. Can we get in-home doctors to go to homes or do home visiting? So I will actually start with you, Dr. Freeman, if you want to answer that question.
I think Laurie would have liked, Director McFadden would have liked to answer that, to say that's why we have community paramedics as well. I think that this is another example of the EMS system trying to reach our patients where they are and get back to where we were at the turn of the century when, you know, the family medicine doc went to the patient, not to the hospital. We've industrialized and institutionalized medicine. And right now we're trying to have a bridge because there are benefits to being in the hospital and having those resources. But we recognize that often if you can see where the patient lives, look at their home, really understand how they're living, and not when they're cleaned up and they come into the hospital, what their environment and the impacts on them are in an acute situation like when they call 911, it is super helpful. There are multiple scenarios across the world that are using doctors, nurse practitioners, physician assistants on an ambulance. There are more, however, that are using telemedicine now with COVID and using alternate care providers like our paramedics or like a nurse or a nurse practitioner. So I do think that you could have a physician do this. However, I think you don't always need, though, you know, I'm a physician. I don't think you always need a physician to do this initial triage and assessment, which often when we're talking about social determinants of health, it involves more medical social work and a team of people who understand the social determinants and can call, you know, a higher level provider just to say, this is what I have and this is what I think is best. So I do think that some type of provider who can touch that patient and address the patient in a holistic way in consultation with another provider is what is needed, but that's not always and not usually, quite frankly, a doctor.
Great, thank you, Dr. Freeman. As a former medical social worker, I couldn't agree with you more. Director McFadden, do you want to add to that at all?
I just wanted to just echo what Dr. Freeman said. Paramedics and EMTs are uniquely qualified as field providers. They really understand what's going on out there, and having eyes, like Dr. Freeman said, on their living circumstances gives us a leg up. And it's easier to hire a paramedic or an EMT to be in the field than it is any other level of clinician, because that's what they've signed up to do. So that makes them uniquely qualified.
Okay, so we don't have any further questions from our attendees. I will give folks another minute or two if they, you know, think of something. But as we wind up, I'm wondering if there are some closing comments that the two of you would like to share. You know, just some key takeaways for folks in thinking about an EMS system redesign. And so I will start with you, Dr. Freeman. Just some closing thoughts.
I am just thankful after a long shift in the ER today. And when I speak to my peers, I trained in the Boogie Down Bronx in New York. And when I ask my peers about the New York ambulance system, when I talk to my peers who are working in other regions across the country, this is innovative. And there aren't many who are trying to address the diversity that we have in Alameda County. And frankly, they don't all have the diversity that we have. So we are forced to be inclusive since we have always been one of the top 5 diverse areas in the country, right? But because of our leadership and because people really are passionate about meeting people where they are, I'm just thankful to see this process be inclusive. And I challenge our audience to keep holding us accountable, keep raising the issues that you see so that we are forced to incorporate them. But I am very optimistic about the CAT team, the CBOs, the community paramedicine, whatever it is, bringing virtual to the EMS. Like what? That's a game changer. So I just can't wait to see this roll out with providers who can relate, have the language, and care about our patients.
Thank you, Dr. Freeman. Before I get to you, Laurie, with closing remarks, we have one more question that came through. Have you considered emergency in-home care, IHSS? This worked well in San Francisco, connected to adult protective services. Director McFadden, is that something you can answer?
We haven't considered that directly. I mean, it's like all of the pieces, we don't have them. We're looking at all of the designs. So we haven't landed on one. So we are looking at all of them. And so, yes, so I'll just leave it there.
That's great. So it's informative, another direction to consider. That's great. Thank you for the question. And so I will ask you then, Director McFadden, to have your closing thoughts, and then I will wind down this forum.
Thank you so much, Tueri, and thank you to everyone who's attended with your very insightful questions. It's been an education, and we're also here to educate you that our EMS system is not going to look like every other EMS system. It's not about the red lights and sirens anymore. It's about getting the right care to the right person at the right time at the right destination. So there are a lot of changes that we foresee, but there are challenges. So we are going to have to look at funding and all of the various integrations that we will need to do to be successful. So I am confident that we will get some of it accomplished, and it will just be a living, growing system. And innovation is key in Alameda County, and making sure that every single one of our citizens gets the correct care is paramount in our minds. So thank you so much for this opportunity.
Great, thank you so much, Director McFadden. So Maylene, if you can advance to the next slide, which is our ending slide. So I would just like to extend my gratitude for all of you who made it. I'm so sorry about the link issues and some of our tech snafus. Much gratitude for your persistence. Many thanks to our interpreters who have joined us and your patience in this, to our colleagues in ITD for getting this going, and HICSA Communications. And I just want to say that we are considering redoing this session. So we will let you know, because not everybody who registered was able to join. In the meantime, please, if you have further questions, you wake up in the middle of the night thinking of something, have any further comments, please email this email that you see here, ems.redesign@acgov.org. And that email box is monitored by our EMS colleagues to continue to receive your feedback and your questions. This presentation and the slide deck will be posted ideally sometime this week on the EMS webpage. And we will work on getting all the slides translated into Spanish, Cantonese, and Vietnamese. And so with that, I am happy to close this community forum. We look forward to seeing you all in the future, and thank you for your input and being here. Appreciate it.